And yeah, let's get started.
Okay, hi everyone. I'm very happy to have you all here today. So like Dr. Ahmed kindly mentioned, we're going to be doing a couple of things today. And it's going to start with the structure and function of the spinal cord and brainstem. I'm well aware that we just went over this the last session, which was held at the 10th, but we're going to briefly go over it again, okay? And the reason for this is, one, to ensure that everyone that is or feeling left behind can catch up with us. And two, the best way to understand the lesions is to make sure you understand the structure and function. So before I proceed, I just want to make sure, can everyone hear me and can everyone see my screen? Okay, so as you can see, it's just much easier if you could just like use your mic, especially throughout the session. If I'm asking questions, please use your mic because it's going to be very inconvenient for me to keep shifting through the two things. Okay, so the first thing for structure and function, we're going to start with the spinal cord. And then once we're done, we're going to discuss the lesions of the spinal cord. And then we're going to go ahead to the brainstem. Within 40 minutes, I'm going to give you not all the details. I'm not going to go in depth into anatomy, but I'm going to make sure you understand how to approach clinically and be able to answer any clinical question in your midterm, inshallah. So I ask for your attention. So the first thing, when we talk structure, you need to be well aware that for motor, we have the corticospinal tract, and I'm sure you've heard that a lot by now. We have the ventral horns. Now, when you say corticospinal tract, that always means an upper motor neuron. When you say ventral horns, that means lower motor neuron. Okay, that's the first thing I want to touch upon. When you say an upper motor neuron lesion, it doesn't in any way reflect the location of the spinal cord or somewhere above near the brainstem or even in the cortex. Upper motor neuron and lower motor neuron do not equal location. They represent higher function. An upper motor neuron lesion is a lesion affecting a higher function, like a tract, for example. While the ventral horns and the peripheral nerves, they're just messengers. They're not higher function, they're lower function. That's why I refer to them as lower motor neurons. Okay, now for sensory, just briefly, we have the dorsal columns and the spinal thalamic tract. So once again, let's look at the motor function. And I briefly just did a little vertebral body over here to just quickly recap for everyone. We always have the central canal in the middle. We have the ventral horns as they are present over here in the gray matter. And in the white matter of the vertebral section where the tracts are, you have the dorsal columns, which are responsible for all sensation except pain and temperature. Pain and temperature is carried out by the spinal thalamic tracts, and to be specific, the lateral spinal thalamic tracts. Now, you also have the corticospinals, which are the higher function motor tracts, okay? And then in the corner, you actually have two of these. You have the anterior and posterior spinocerebellar, which we're gonna get into a sec. I don't wanna confuse. Just a quick overview. So motor function, upper motor neuron versus lower motor neuron. Now, every time I explain this, I love to draw these multiple vertebral bodies. And the reason for that is what you have in black over here, right? You have the ventral horns. And out of every ventral horn, you're going to have a motor nerve, let's say, that comes out, okay? And each motor nerve that comes out of every single ventral horn, that's every single vertebral body, is independent. They have nothing to do with each other. Okay, that's point number one. Point number two, the corticospinal tract. It is singular. It is one body. It is a higher function. It's one big boss who's there and is present throughout the whole time. The reason I'm mentioning this is because if at any point, let's say I knock out this whole vertebral body. When I knock out this vertebral body, I am damaging the corticospinal tracts as well as the ventral horns, and even the peripheral nerve that is coming from that segment. Okay. Now, I always like to mention this because it's important for us to remember that the corticospinal tract's job or function is inhibitory. The corticospinal tract always inhibits the ventral horns. Okay. And the ventral horns, their function is to always stimulate. Okay. They keep firing excessively, overstimulation. So when I damage the ventral horns, I will never have stimulation. And that's why in lower motor neuron lesions, you get a floppy or a flaccid paralysis and decreased reflexes and tone, etc. Now, the corticospinal tract, again, what the corticospinal tract does is it always sends inhibitory functions. As a rule of thumb, any higher order process in the nervous system is always inhibitory. It is harder to stop something than to do something. Okay, that's how the nervous system works. So the corticospinal tracts, if we damage them, again, we're going to our example of this vertebra, where we have damaged the corticospinal tract. Everywhere below, where the corticospinal tract used to send inhibitory signals, these inhibitory signals are no longer over there. And therefore, the ventral horn starts overstimulating. And that's why when you have an upper motor neuron lesion, you always get spastic paralysis, hyperreflexia, hypertonia, etc. Is this clear for everyone? Now, the one point I really want to stress on is at the level of the lesion. The reason at the level of the lesion, you always have a lower motor neuron lesion, even though the corticospinal tract is affected or destroyed, is because the ventral horn and the peripheral nerve exiting the ventral horn at that segment is also destroyed. So regardless whether you have negative inhibitory stimulation from the corticospinal tract or not, it doesn't matter because the ventral horn at the lesion is also destroyed and will not be able to stimulate at all. Is this clear? Please use your mic.
Doctor, could you just repeat that, please? So you're saying that the lower motor neuron lesion will be damaged at that segment?
Mm-hmm. So if this is a vertebral body right here, and these are the ventral horns, okay, and let's say we have another vertebra up there, okay, and here we go, let's just draw it real quick. Okay, so I have my corticospinal up here, right? If I have a lesion up here at the corticospinal tract, technically, at the vertebral level below, you will not be able to send negative or inhibitory signals to the ventral horn. Is that correct? And therefore, the ventral horns will overstimulate via their peripheral exiting nerves, right? And you're going to have spasticity. Okay? But let's say, for the sake of example, you have two separate lesions. Let's say you have the same exact lesion over here, and the corticospinal tract is affected. But for some reason, the peripheral nerve is also destroyed. There is no peripheral nerve. Will this nerve be able to send any spasticity? No, it won't. So at the level of the lesion, forget all of this. At the level of the lesion, at the level of the lesion, corticospinal and the ventral horns. At the level of the lesion, if I knock out the entire segment is gone. Yes, the corticospinal tracts are gone, and I should have spasticity in an upper motor neuron lesion. However, the ventral horn is also knocked out, and the peripheral nerve exiting at that segment is also knocked out because I killed the entire segment. So at the level of the segment, regardless of whether the corticospinal tract is destroyed or not, the ventral horns and the nerve to send the motor input is gone as well. So regardless of anything, I have absolutely no movement. There's nothing. So it's flaccid paralysis. But the level below, this vertebra below, The peripheral nerve is working perfectly. And so is the ventral horn. And over here, the ventral horn, we said it's always overstimulating. And the negative messages that we get are via the corticospinal tract. And we said the corticospinal tract is singular. It is just one body. If it's damaged above, it cannot go down. So at the segment below, you cannot inhibit the positive stimulation that is always fired by the ventral horn. And therefore, the level below, you're going to have spasticity, spastic paralysis, and hypertonia and hyperreflexia. Is that clear?
Yes, that makes sense. Thank you.
Perfect. You're welcome. So this is the concept of the motor aspect for neurology. And we're going to discuss the brainstem when we get to it. Okay. Now, sensory. Sensory, we have a couple of things. One, we have the dorsal columns, which you could see. You have two vertebrae here, 1 and 2. And can anyone tell me what the difference between these two? I know my drawing is horrible, but can you tell the difference between the two?
Doctor, can you repeat your question?
So my question is, I have two dorsal columns and two vertebrae, number 1 and number 2. Can you tell me what the difference between them is?
I think number 2, it doesn't have the fasciculus cunatus.
Cunatus or gracilis?
It doesn't have the cunatus, it has the gracilis.
Okay, so let's make two things clear. One, you're thinking of the right way, and you're absolutely correct. You have one vertebral level, number 1, has the dorsal columns divided into the fasciculus gracilis and the cunatus. Okay, number 2 only has one. All right. Now, what I want to make it clear over here is that 2 is going to be somewhere above. It's going to be a higher vertebral body than 2. Okay, because the way, if I were to draw the dorsal column, for example, and let's have it divided, right? The dorsal column is, I'm going to do a stick figure as simple as that is. It's arranged in a way like your body, okay? With the inner portion, which is the gracilis, supplying the lower limbs, okay? And the outer portion, which is the cunatus, think of it as cutaneous. Cutaneous means skin. The skin is always outside, okay? It is where your upper limb is. Okay, so that's just as simple as that. That's what I want to discuss over here. The dorsal column is divided into the fasciculus gracilis and the cunatus. The gracilis is the lower limbs and the cunatus is the upper limbs. It's just like how your body is organized. Now, can someone tell me what the function of the dorsal column is? And I've already mentioned it. The function of the dorsal column is all sensation, except
Pain and temperature.
pain and temperature. Excellent. Okay. So what is responsible for pain and temperature? The spinal thalamic tract. Okay. And this over here is the spinal thalamic tract. And I know everyone is saying now, well, we have the lateral spinal thalamic tract, and that is what supplies pain and temperature. So what on earth is the anterior spinal thalamic tract? Well, the anterior spinal thalamic tract are these little two irrelevant figures over here. What are they responsible for? They're responsible for crude touch. Does anyone care about that clinically? Will you ever be asked about that clinically? No, you will not. You might be asked an MCQ. But the anterior spinal thalamic tract, we do not care about it. The function of pain and temperature is by the lateral spinal thalamic tract. Now, just for the sake of further explanation, the corticospinal tracts are posterior a little bit to the spinal thalamic tract. The lateral spinal thalamic tract are anterior to the corticospinal tract. Okay. Now we have, are these the only two tracts responsible for sensation, or are we forgetting one tract that we probably didn't discuss in depth?
Spinocerebellar.
Excellent. So spinocerebellar tract. Oh my God, what is that? Anterior spinocerebellar and posterior, what on earth is happening? So in a nutshell, again, the cerebellar tract does play a role with proprioception. I don't want to confuse you. You have conscious and you have unconscious proprioception. The proprioception responsible with dorsal tract is always associated with the vestibular nuclei, as well as the the optic and the vestibulocochlear nuclei. because in general, the dorsal columns are responsible for conscious proprioception, and it takes input from multiple sources to let you know how to walk, maintain balance, etc. Spinocerebellar tract, and I'm going to explain something important in just a second, is responsible for unconscious proprioception. Okay, and you have two spinocerebellar tracts. Okay, the spinocerebellar tracts are going to be located here and here on both sides, of course. Okay, so you have the anterior and you have the posterior spinocerebellar tracts. Okay, so why am I mentioning this? In a nutshell, the posterior spinocerebellar tract can be completely ignored. Okay, it comes out of the vertebral body ipsilaterally and it goes straight to the cerebellum. No issues there. The anterior spinocerebellar tract, which is also referred to as Clark's column, decussates like the spinothalamic at the level of the spinal cord, ascends contralaterally. But then guess what? When it reaches near the midbrain, it decussates again to go back to the ipsilateral cerebellum. So in general, spinocerebellar tract injuries, which you will not be asked about, are ipsilateral. Just like the cerebellar injuries in general are always ipsilateral. The only reason I'm explaining this right now is just for you to understand the concept. There are no clinical manifestations except in subacute combined degeneration, which I will explain when I get there. Okay, is this clear?
Doctor, I have a simple question.
Go ahead.
So the anterior spinocerebellar tract, so it decusses twice. That's why we just say
Yes.
it's ipsilateral.
Exactly.
And the second decussion is where exactly?
At the level of the cerebellum near the brainstem.
Oh, okay.
Okay.
Thank you.
You're welcome. Now, just for the sake of, I was going to explain it in the overview, but just for the sake of complete explanation, I'm going to come back to the dorsal columns. And I want to make it clear that the dorsal column does ascend from the vertebral body. Let's say this is the right side. It ascends from the right side till it reaches the medulla and it decussates to the other side. We all know that, correct? The corticospinal tract descends, decussates at the level of the medulla and descends down to supply the contralateral side. And lastly, the spinothalamic tract, which is pain and temperature, the lateral spinothalamic tract, it decussates at the level of the spinal segment, then it ascends. And I'm drawing this specifically because I'm going to show you something right now, okay? So to overview everything, let's just come down over here. And let's just realize one thing. The corticospinal tract, I just drew it and I want you to look at it once again. The corticospinal tract, as the name suggests, corticospinal. It comes from above because it's motor input. The mind is telling the body, hey, move. So it has to come from above and go down. So it's a descending tract. But this only confuses you. When you think of the motor as descending tracts and the sensory columns, right? They're responsible for sensation. So obviously you're going to feel things from the body and they have to ascend and go to the brain in order for those sensations to be interpreted. But if you keep thinking of yourself or of these tracts as descending or ascending, it might confuse you. So it doesn't matter. When you're solving clinically, it doesn't matter whether it's ascending or descending. Don't think like that because you're going to start mixing up where the decussation is and how the sensation is going or the motor. Do not think of that. I just want you to always know one thing. On the left side of the body, the corticospinal tract, which is in red, will always ascend on the left side ipsilaterally. then it will decussate and go to the right brain. The dorsal columns, which are responsible for all sensation except pain and temperature, will ascend on the same side and then decussate at the level of the medulla. Lastly, the spinal thalamic tract, the nerve actually from the left hand, goes into the spinal segment and does not touch the left spinal thalamic tract. No, it ignores it, travels through the anterior commissure to the opposite side, at the right side. That's where it relays with the right spinal thalamic tract. And then it ascends contralaterally to begin with. Is this clear?
Yes.
Okay, so here comes my golden rule, number 1. A lesion at the spinal cord. So you always can differentiate if a lesion is at the spinal cord or if it is in the brainstem by one simple thing. You search for cranial nerve involvement, right? We all know that. You look for there's paralysis in the face, something wrong with the tongue, something wrong with the eyes. Okay, that's obvious. But if I give you only tract or spinal tract symptoms, you might get a little confused. And there's a rule. It is never wrong. In a lesion in the spinal cord, you will always have ipsilateral damage to the corticospinal tract and the dorsal columns, while you will always have contralateral damage to the spinothalamic tract. So for example, let's take a damage right over here. We just damaged the spinal cord. We don't care about anything above. Just ignore that. Let's just look down. If this side is damaged right now, you will have left-sided loss of movement or left-sided weakness. You will have left-sided loss of all sensations except pain and temperature. But you will have right-sided loss of pain and temperature. Okay, it will be contralateral. And I'll show you why in just a second. Maybe this diagram isn't super clear here. Okay, but it's simply because as we drew it, we can always see that the dorsal column and corticospinal tract, they only decussate at the level of the brainstem. So we will not have an issue there. However, any lesion to the spinal thalamic tract, right, the ending. So over here, for example, it seems like the okay, I drew it on the right side, but that doesn't matter. If the right spinal thalamic, in this case, we're going to be damaging the right side, which decussates to the other side. Okay, I'm going to show you in a diagram in just a second. Just bear with me. Now, if we have a lesion in the brainstem, which is going to be above over here, can you appreciate that everything is on the same side? Everything's already decussated. Whether we decussated down here or we decussated above, it doesn't matter. The lesion affected all tracts, and all tracts, because this is above the medulla, all tracts below the lesion will have to cross to the other side. And therefore, a lesion in the brainstem will always have contralateral damage or sensory. Okay? So any case you get in your exam, the first thing you do, look at weakness in the body. Is the weakness in sensation? Yes. Okay, then we're probably dealing with the brainstem. Do we have loss of motor movement on one side of the body and loss of sensation on the same side, but loss of pain and temperature on the other side? Then I don't care what the case is, this is 100% in the spinal cord. Is this clear?
Yes.
Okay.
So just to, doctor, anything in the brainstem is going to be at the same side. So you it wouldn't be like loss of sensation on one side and then loss of motor function on the other.
Everything will be on the same side in terms of symptoms, but everything will be contralateral to where the lesion is, right? Because everything decussates.
Yeah.
The corticospinal tract comes down and it decussates at the level of the medulla. The dorsal column comes down and it also decussates at the level of the medulla. The spinothalamic goes all the way down on the same side, then it decussates to the other side. So regardless what happens, if above the medulla, I get a lesion, well, everything is screwed on one side pretty much, right? So we lose everything contralaterally. Clear? But if it's at the level of the spinal cord, the spinothalamic tract is playing tricks on us because it decussates. It doesn't relay to the ipsilateral spinothalamic tract. No, the sensory nerve enters the dorsal ganglion, skips the ipsilateral spinothalamic tract, and goes ahead through the anterior commissure to land on the opposite side. So in the spinal cord, we will always have ipsilateral corticospinal tract and dorsal column damage, but contralateral spinothalamic tract. This is simple, right?
Yes, because the corticospinal and the dorsal column are going in the same direction to begin with.
Yes, yes, group them together. The corticospinal and dorsal column will always be together.
Yeah.
Okay?
Okay, thank you.
Right. Except at the level of the midbrain, anyways. But we'll get into that in a second. Right. Now, let's discuss spinal cord lesions. This is the next objective. So we figured out the first thing we discussed was a general overview of structure and function, and everyone is clear on that, right? Okay, so there are two questions you have to always ask yourself. Is it unilateral or bilateral? If it's unilateral, it's probably a trauma. It's a lesion. It's an infarct. It's something ischemic. It's something happening. If it's bilateral, then it can be a autoimmune disease, right? It can be, for example, an infection. It could be complete destruction. And it can also sometimes be ischemia, okay? But most of the time, infarction or ischemia is going to be unilateral. Not all the time, this is not a rule. It's just for you to understand, to categorize in your brain before you're even starting to guess or have any differential diagnoses. You need to ask yourself. You isolate the symptoms. Number two, you need to know, is it only sensory or is it motor? Because if it's only motor, then you're only going to think of diseases that affect either the ventral horn or the corticospinal tract, and it's pretty straightforward. And if it's only motor, then you ask yourself, is it upper motor neuron lesion? Do I have spasticity and the hypertonia and hyperreflexia? And if it's eventual, if it's only motor disease, for example, then you ask yourself the other question is, okay, is it lower motor neuron? Do I have flaccid paralysis and hypotonia and hyporeflexia or fasciculations, etc.? Okay, keep in mind something very important. Whether it's a lower motor neuron lesion or an upper motor neuron lesion, you will have atrophy. Now you might ask why. It's simple. In a lower motor neuron, there is no innervation. It's flaccid paralysis. You lose muscle mass. In an upper motor neuron lesion, there is spasticity and the muscle is always contracting. So you might think the muscle might hypertrophy or get bigger. And that could be true technically when you think about it. However, the muscle fatigues. It gets tired. And once it gets tired, it stops contracting and you get, I'm disoriented. And you get atrophy. Clear? Okay. So the first thing we're going to discuss is, let's take you see this spinal segment over here. Let's take the left side. And let's say you got in a car accident and we knocked the entire thing out. So let's go one by one. What symptoms are we going to get? We damaged the entire half of the left spinal segment. Now, let's do it one by one. First of all, we group the corticospinal. Let's do motor, then let's do sensory. Okay? So motor, what do we have? One, we have damage of the corticospinal tract, right? And let's say, for the sake of explanation, let's say this is a lesion at T5, for example, vertebral body. Okay? So motor, we have damage of the upper motor neuron. We have damage of the corticospinal tract. But at the level of the lesion, remember I just explained it, even though the corticospinal tract is destroyed, but so is the ventral horn and the peripheral motor nerve coming out of that segment. Everything is destroyed. So at the level of the lesion, will I have a lower motor neuron or will I have an upper motor neuron? Will I have flaccid paralysis or will I have spastic paralysis?
Lower motor neuron lesion.
Exactly, because regardless of whether the corticospinal tract is sending inhibitory signals to the ventral horn, there is no ventral horn or peripheral nerve to carry out excitatory signals. So one, you will get a lower motor neuron at the site of lesion. And the second question I ask myself is, we said that the corticospinal tract in a spinal cord injury will always be what? Ipsilateral or contralateral?
Ipsilateral.
Ipsilateral, excellent. So we're gonna have ipsilateral flaccid paralysis or hyperreflexia. We're gonna have an ipsilateral lower motor neuron at the side of the lesion. Okay, so we did that. So now there's another easy part. So now below T5 at T6 and T7, what are we gonna have? Are the ventral horns okay or are they damaged at T6 and T7? They're perfect, they're fine. But the corticospinal tract above was destroyed, so we don't have inhibitory signals. So guess what? T6 and T7 are going to be overstimulated because there are no inhibitory signals from the corticospinal tract. Because at T5, it was destroyed, right? On the left side, right? So therefore, below the level of the segment, you're always going to have an upper motor neuron lesion below the segment. Again, is it going to be ipsilateral or contralateral? Ipsilateral. It will always be ipsilateral. Excellent. Okay. Now for sensation, what tracts do we know? We know one. We have the dorsal column. What is the dorsal column responsible for?
All of the sensation except temperature and pain.
Excellent. All sensation except pain and temperature will be lost. Where?
Ipsilateral.
Ipsilateral. Excellent. Okay. All right. Now we have one more, and that is going to be the, so over here, just so we know, this is dorsal column. The third thing, part of the sensory, is going to be pain and temperature. Okay. Let's just take a second before we answer that, because there are two parts to this. Okay. And remember above, when I told you I'm going to explain it in a clearer picture, that's what I'm about to do right now. So again, mind my drawing, because I know it's horrible. Okay. But let's just say, oh, that was excellently horrible. Okay. So let's just say these are the spinal thalamic tracts. Okay. This is the right side and this is the left side. Okay. The left sensory nerve, obviously sensation always enters dorsally, right, in the spinal cord, but just for the sake of explanation, the left nerve comes in, it skips the left spinal thalamic, it doesn't even touch it. And it goes through the anterior commissure to go into the right spinal thalamic tract. Okay? The right side of the body has sensory nerves which enter from the right side and they skip the right spinal thalamic tract to touch or relay information to the left spinal thalamic tract. This point where they meet is called the anterior commissure. So if I damage half the segment over here, I will lose the spinal thalamic tract. But more importantly, on this side, I am also damaging what? The sensory nerve. It doesn't even enter into the vertebra. It's already damaged. All of this is injured. This is all gone. And the peripheral nerve, I hope it's clear. It still didn't enter anywhere. It's damaged as a result. Okay? So even though the spinal thalamic tract is always contralateral, at the site of the lesion, at the level of the lesion, okay? At the level of the lesion, you lose pain and temperature ipsilateral. Okay? But below You lose contralateral, opposite side, pain and temperature. Is this clear?
Doctor, I have a question. Why isn't
Go
it
ahead.
bilateral loss at the level of the lesion?
Okay, because every spinal segment that comes out, especially from the spinal thalamic tract, it actually has to go down one spinal segment before it relays. But I'm just skipping this because I don't want to go into too much anatomy and confuse you guys. But at the spinal nerve entering the segment, as you know, enters from a couple of segments below that vertebral body. So at the level of the lesion, the spinal thalamic tract, this tract over here that's damaged, for example, is actually that of the spinal nerves below, okay? But the spinal nerve at this segment, which enters and relays to the vertebral body above, which is not damaged, but the sensory nerve itself is damaged as a result of the loss of the half of the vertebral body. So that is why at the level of the lesion, you don't lose bilateral. No, you lose just the same side. Okay. Is that clear?
So, doctor, can I just ask?
Yes, it is.
Yes, please ask.
So you're saying that, like, so if you have it in a clinical scenario, because normally they say that the patient has lost contralateral pain and temperature loss. But you're saying that, like, if they said that, you would, and then suddenly they said that this nerve was still intact, then the reason for it that this nerve was lost though on the same side, would be because at the level it's ipsilateral, but then below the lesion everything is contralateral for the spinal thalamic tract?
At the level of the lesion, it is what? Sorry?
At the level of the lesion, then they would have an ipsilateral paralysis in that a sensory loss in that nerve at that segment, but then everything below that would be
is contralateral. Exactly. Okay. Yes, because at the level of the damage, guys, every time we destroy the entire vertebral body, we're not only just damaging the bone. No, there's soft tissue around, there's blood vessels, there's the nerves entering. So in our case, it's the actual peripheral nerve. It's not even in the vertebral body at this point, but it also gets damaged as a result of a complete hemisection of the spinal cord. So that is why at the level of the lesion, it is still ipsilateral. It doesn't matter, okay? Because it got damaged before it even gets to go and decussate to the other side. On the site where the sensory information is being taken to be processed by the contralateral spinal thalamic tract, that nerve is gone. There's no messages. So on this side of the body, if we had an arm, again, I like to draw stick figures, just pretend this is an arm, then this arm has no sensation and it's going to be on the same side. But everywhere below the body, because the nerves will ultimately relay everything to the spinal thalamic tract to go up, and the peripheral nerves are okay below the segment, but the spinal thalamic tract is damaged or injured above, then you will lose all pain and temperature sensation below the level of the lesion contralaterally. Clear?
Doctor, just to make sure I got this, the side, the ipsilateral nerve that enters, it's going to ascend like a level or two, right?
Yes.
Okay.
Yes.
But it's damaged before it even gets to do that.
Exactly. And that's why it is ipsilateral at the side of the lesion.
So, the point about you saying that the nerves come down before they fly, is that for all nerves or just the spinal thalamic?
Spinal thalamic. So in general, the spinal nerves, if you remember, they come down. So it depends on the location in general. So for example, the vertebral body, you have vertebral body 1, you have the spinal nerve, it comes below it. The second vertebral body, you have, after the second vertebral body, the spinal nerves that come out are actually 2 spinal nerves below that vertebral body. After the third vertebral one, there are always 3 segments below, and it maintains to be 3 segments below after that. But for the sake of explanation, and again, clinically, the spinal thalamic tract, specifically in this example, I just want you to stress on it. For everything else, I don't want you to think about that. And again, this is for clinical attempting. For clinically, I just want you to understand that the spinal thalamic tract, if we have half a loss of the spinal segment, you get ipsilateral, even though we all know that the spinal thalamic tract is always contralateral. The reason for that is because the peripheral nerve is damaged. I don't want you to confuse yourself. Okay, clear?
So doctor, at the level of the vertebra, like at the lesion, we lose everything ipsilateral?
Yes, excellent. So at the level of the damage, you will lose everything on that side. Again, because regardless of what nuclei or tracts or whatnot I have, at the end of the day, there's a spinal nerve that comes out. And the spinal nerve, we all know that the spinal nerve is a mixed nerve and it has dorsal and motor sensation. That's just another way to make it very simple. This spinal nerve has to enter at this point. So if I have a very severe injury and the peripheral nerve is damaged, then ipsilaterally, we're going to lose everything. This is another simple way to just look at it. But the way I like to explain is I don't explain this because it's very dry. It's too simple. Okay. So just for you to understand, you need to always in urology, especially clinical scenarios, to see a symptom, isolate it, and understand how to trace it. And that's what I'm trying to do here. So one more time to recap. If I ruin the left hemisection of the if I take out the entire left segment of the spinal vertebral body, I damage the corticospinal tract and the ventral horn. Motor-wise, we're speaking, right? So therefore, at the site of the lesion, we know it has to be a lower motor neuron because the corticospinal, it's a higher functioning process, which relays its information to the messenger, and the messenger is the ventral horn, but the ventral horn is also damaged. So regardless of anything, at the level of the lesion, we have ipsilateral lower motor neuron paralysis. Below the level of the lesion, you're always going to have an upper motor neuron lesion ipsilaterally. For the sensation at the dorsal column, once again, our golden rule, spinal cord, it is ipsilateral, loss of all sensation except pain and temperature. Now, below the lesion, pain and temperature is going to be lost contralaterally. And we all know that that's simple. But at the level of the lesion, even the pain and temperature will be lost at the side of the lesion, because at the side of the lesion, the peripheral nerve is damaged before it gets to decussate and go to the spinal thalamic tract. Is that clear?
I have a question. So now the way that you mentioned that the pain and temperature will be lost at the same like level, ipsilateral, right?
Yes.
Is it going to present as a dermatome? Like how? Like
it
how
could. 100%. Yes, it could. Yes, 100%. Okay. Even if you search. So before I tell you about that, what disease is this? What we're describing? Can someone tell me?
ALS.
Brown
syndrome.
Syndrome, yeah.
Okay. When you have complete loss of half the vertebral body, and we have ipsilateral loss of everything at the site of the lesion, and loss of upper motor neuron paralysis below the lesion, and loss of pain and temperature opposite below the lesion, then this is known as Brown-Séquard syndrome. Another very simple way for you to remember it is you lose the dorsal column and corticospinal on one side, and you lose pain and temperature on the other side. But you have to know these details in case of MCQ. Okay? Type. The next thing we're going to talk about is going to be, I'm going to actually give you two examples right now. Okay? So we have a vertebral body over here. And let's say my only symptom. So number one, I need to ask myself, is it bilateral or unilateral? Even before I give you a case scenario. So as I'm making up my question, I need to ask, is it bilateral or unilateral? So let's say it is bilateral. Okay. All right. So I have bilateral. What do I have? Is it motor or sensation? I have bilateral, let's say, sensory loss. Okay, excellent. What type of sensory loss do I have? So you tell yourself, okay, pain and temperature are there. That's good. But I lost all sensation. Okay. Other than pain and temperature. Now you double check, are you sure there is no motor? Yeah, there is no motor. We have no motor issues. Motor is fine. It's good. It's working. We only have isolated sensory loss of vibration, proprioception, and sensation in general. Okay, clear? Type. So what is damaged? Someone tell me, what tract is damaged? Do I have damage to the corticospinal tract?
Dorsal column.
The dorsal column.
Excellent. So corticospinal is okay. Spinothalamic is all right. Do I have any paralysis? We said no, so it's mafrud corticospinal is okay, and ventral horns are okay. طيب. Pain and temperature, no, it's okay. Do I have ataxia or ataxia? Maybe. Okay. So, but أنا قلت لكم in the very beginning, remember, spinocerebellar, completely forget about it. Okay. طيب. So what's damaged? We said the dorsal columns. And we know it's bilateral, right? Okay, so it's bilateral, so we crossed it out on both sides. Type, what are these two dots over here? These are known as Lesions tracts, and they're not important. Don't worry about them. But what's more important to me is to always remember that the dorsal column is also associated with the dorsal root ganglia, which has the deep tendon reflexes. So you will also lose reflexes if you have damage to the dorsal column. Okay? Type. So what disease is this? When you have bilateral loss of all sensation.
Tabes
dorsalis.
Excellent. Excellent. So this is going to be tabes dorsalis. What causes tabes dorsalis?
Syphilis.
Tertiary
Tertiary syphilis.
Excellent. Excellent. Okay. So in tertiary syphilis, you also have a Romberg sign. What's that? Basically, if I ask you to stand and put both your feet together, okay, with no space in between them, with your eyes open, you're going to be okay. But if I ask you to close your eyes, you're going to fall. Okay? And the reason for that is conscious proprioception, which is the proprioception responsible by the dorsal column, like I mentioned earlier, is also associated with the vestibular cochlear nuclei, as well as the so it gets sensory innervations from the optic nerve, as well as the vestibulocochlear, etc., etc. Okay, so if you close your eyes and you're no longer, so the eyes also have a role in having the vestibulocochlear assess the balance, right, as well as obviously the ears. But if you close your eyes, you knock out one of the inputs, then you fall. Anyways, I don't want to get too much into that, but just remember, Romberg. You see that on your MCQ, you're going to think tabes dorsalis. طيب, let's just change this around. Let's just, same scenario, but let's just change everything around really quick, okay? So let's say everything is okay, okay? Or sorry, let's say that, come on, Marra, let's build a question together. Is it bilateral? Whatever it is that I'm going to talk about, I'm going to say yes, it is. Okay, so it's bilateral. 2, is it motor? I'm going to go ahead and say yes. Okay. Now I'm going to ask, if it's motor, what's the first thing I ask? Is it upper or lower? Is this upper motor neuron or is it lower motor neuron lesion? I'm going to tell you, at the site, it is lower. Below, it is upper motor neuron lesion. Type. Do we have sensation? I'm going to say, no, sensation is gone. We don't have pain and temperature. We don't have that. But sensations of proprioception and general sensation and vibration are intact. So in this case, what I highlighted in the dorsal columns are okay, but the corticospinal is not. The ventral horn is not, and the spinothalamic is not. Is it bilateral? Yes. So everything is destroyed. But I have proprioception, I have vibration. And you know what? Do I have deep tendon reflexes? Yes, I do. So what am I talking about?
Anterior spinal artery syndrome.
Excellent. So it's called anterior cord syndrome. And it is as a result of damage to the anterior spinal artery. You are absolutely correct. Can someone be a little bit more specific? Do you know below what segment?
Occlusion of the anterior spinal artery.
Okay, you're absolutely right. So
T8.
The anterior spinal artery, when it reaches around T8, yes, excellent, whoever just said that. Below T8 is a watershed area. Watershed means usually whenever you have an arterial blood supply, you also have a branch, you also have another artery, for example, that goes and anastomoses with the artery. So if that one part of the artery is blocked, you still have blood flow to supply it elsewhere. okay? But the anterior spinal artery territory below T8 is supplied by the, I have no idea how it's pronounced till this day. It's Adam Kiwis or whatever it's pronounced, okay? The artery of Adam Kiwis, okay? This artery has a predisposition to, since it is watershed area, it is the only thing that supplies the anterior spinal artery territory below T8. If it is damaged, and it is, yes, it is a branch of the anterior spinal artery. You are all absolutely correct. You will get this picture. And this is known as?
Anterior cord syndrome.
Excellent, okay. So the way I have it grouped for you is to understand. So to repeat in a nutshell, the anterior spinal artery, everywhere above T8, has other arteries which supply or give blood supply to the vertebral bodies, okay? But below T8, the ASA has a branch called the artery of Adam Kiwis, okay? Or Quiz or whatever. This artery has a, if it were to get ischemic or blocked, there's no faza, there's no ta'ziz, it has no friends, it's lonely. If you block it out, it gets depressed. And by depressed, I mean you get ischemia and the entire vertebral body dies. However, the dorsal column is spared because it has a different blood supply. Okay, that's all there is to it. So just 1 second. I need to take a moment just to emphasize this point for everyone. The dorsal columns, you can look at it isolated. Is the dorsal column spared? Do I have an affected dorsal column? If I only have an affected dorsal column, I don't need to think about anything else. And the way you know that is you underline the symptoms, and I have a case coming up and we're going to underline symptoms. I'm going to show you how it is. You underline the symptom and you ask yourself what tract is responsible for this. And you go back, oh, okay, spinothalamic. Oh, okay, dorsal column. And you write it down or you note it in your head if you have decent memory. If you have a presentation of things that are only affecting the dorsal column and the dorsal columns only, then this is instantly tabes dorsalis and it cannot be anything else. On the other hand, if everything is damaged, but the dorsal columns are the only thing that are alive and they're functioning properly throughout the body, then instantly this is going to be anterior cord syndrome. Okay, clear?
Yes, doctor.
Okay, listen, we're running out of time, so I'm not going to be able to answer all questions, but I promise I'm trying my best to be as clear as possible. Okay, now we have two vertebral bodies over here. And remember, let's talk about the spinal thalamic tract once again. Let's say that, so this is the right side and this is the left side. Let's say the left sensory nerve enters. Again, we always said it doesn't even touch the left spinal thalamic, but it goes and it relays to the right spinal thalamic tract. Okay, actually, right. Okay, so it comes in and it goes to the other one. And on this side, it also comes in, it skips it, and it goes to this side. Okay, we all know in the middle of the vertebral body, you have the gray matter, which surrounds the spinal canal, and the tracts are always in the white matter. Now, let's say for whatever reason, I have something. There is something that is growing in the spine. So the spinal canal is usually going to have your the spinal cord itself, and you're going to have the cerebral spinal fluid and whatnot. Let's say there's something growing on the inside. And you know what? At this point, it's okay. That's not going to do anything. But if it starts growing and growing and growing, guess what it's going to hit? This is called the anterior commissure.
Anterior one.
Okay, so sure, the anterior horn, you're right, but not really, because the way I drew it, it looks like it crossed out the anterior horn, but out of the compression itself, the anterior horns are actually spared, and the only thing that happens is that you actually just lose the anterior commissure. So maybe my drawing wasn't super clear. Usually, hatta, in this case, you do not have here. Wait, let me just redraw it again. Okay. So these are the anterior horns. And then this is the central canal. As this increases, the ventral horns are spared. Hatta this is usually like that, sorry. Okay, and the ventral horns are actually, right? It follows the same concept of the vertebral body, and the ventral horns are going to be here, okay? This is your central canal. As the central canal starts to grow, it will not touch the ventral horns. But over here right away is where you have the anterior commissure, okay, which is the spinal tract décaissé to the other side. Okay, so actually the ventral horns are not affected. I apologize, my drawing is horrible. Okay, type. So what's affected? Come on, Mara, over here. This is the anterior commissure. What is the anterior commissure or anterior white commissure? What is that? We just said it.
Crossing of the spinal thalamic tracts.
Exactly. So it is the point where the left spinal thalamic tract enters right anterior to the gray matter to go to the right spinal thalamic tract in the right white matter, and the right nerve enters and skips the right spinal thalamic tract to pass through the anterior commissure to relay to the left spinal thalamic tract. We already discussed all of this. This X here, this intersection is called the anterior commissure. So if I have something in the spinal canal which is growing, it's going to compress the spinal commissure. So guess the anterior commissure, sorry. So guess what's going to happen? Do I have anything motor? No, I don't. Do I have anything sensation? Yes. What is this lateral spinal thalamic tract responsible for?
Pain and temperature.
Excellent, pain and temperature. Now, number one question, I answered question number 2, which is motor sensory. But question number 1 is this going to be bilateral or is it going to be unilateral? Bilateral. Excellent. So let's just draw a stick figure again because I'm so happy with my drawing skills. Okay, let's say this stick figure. Now, usually I'm describing a disease called syringomyelia. Okay, type. So syringomyelia, you get somewhere around the cervical vertebra to the lower or to the upper T vertebras of the body. Now it is around this point you remember C4, or sorry, C5. C4 is the phrenic. From C5 to approximately T1 was your brachial plexus, which is responsible for the upper limb, correct?
Yes.
So syringomyalgia will have an affinity towards the upper limb, but not the lower limb. And you will lose what? Pain and temperature. So in syringomyalgia, it is because you lose sensation in the upper limb and the shoulder and part of the torso. You lose pain and temperature only. It is described as
cape-like
distribution or loss of pain and temperature. Do I have any motor issues? No. Is my vibration, proprioception, and sensation intact? Yes. It is only pain and temperature. Type. Let's quickly take a look at something else. Same concept. Let's say I have something in the central canal and it's growing or it's dying or whatever, and it's just increasing in size. Okay? Guess what's going to happen? Are the spinal thalamic tracts themselves damaged? No, but we just explained, regardless of anything, we have the spinal, they come and they relay, right? They come and they relay opposite. Sorry, 1 second. Okay? So the spinal thalamic tracts are not touched or affected, but the nerves going to where they are affected, sure. So we can have loss of sensation. But more importantly, we've touched upon what now? The corticospinal tract. Did we damage all of the corticospinal tract? No.
No.
Do we have some spare fibers that are going down? Again, we're talking, let's say this is again at, let's say this is happening at C7. Okay, so let's say this is C7. Okay. So the corticospinal tract is partially affected, yes. But other fibers that are going down to the lower limb are still okay. This is just one of the exceptions where you can ever see we're going to have motor dysfunction. And that motor dysfunction is going to be weakness, not even paralysis. It's going to be weakness, okay? But weakness that is more present in the upper limb than the lower limb, okay? You won't see this anywhere else. What is this?
Central cord syndrome.
Yes. Okay. So this is central cord syndrome. Clear?
No, doctor, I have a question.
Go ahead.
How do I differentiate between them in a clinical scenario? Because they seem to have the same presentation.
Cape-like distribution. No motor issues whatsoever. You can even get a picture of an MRI, of a sagittal section, of the, for example, cerebellum. and it tells you there's ectopia or there's something wrong with the vermis of the cerebellum or whatever, because syringomyalgia, which we said is C, lower cervical segment and the upper thoracic segment, is associated with a malformation called Arnold malformation type, I believe type 1 it was, okay? So you can get a case telling if there's something wrong with the cerebellum. But even if they don't tell you that, there's a classic disease. It only affects the spinal thalamic tract in a cape-like distribution, done syringomyalgia. If I have a case where I have weakness in the entire body and it is bilateral, but it is more in the upper limb than in the lower limb, what do you think of?
Central
cord syndrome. Okay.
Okay.
Type. Central cord syndrome, by the way, just for the record, it's not discussed in the first aid USMLE, but we like to ask it in our lovely lab. So it's important for you to know. Okay. Type.
Why is the lower limb cleared?
So it's just because you could say that there's slightly affected or slightly compressed portion, a very little portion of the corticospinal tract. It's a very little portion that it affects that area directly. But it's so little that the corticospinal tract, in this one exception, in this one disease, is able to carry out to the areas below. That's why in a clinical scenario, if you just see this, and yeah, you just see upper limb weakness more than lower limb weakness, you will not have paralysis because not the entire cord is gone. You will see weakness, okay? They're gonna tell you muscle strength is 4+ in the lower limb and 3+ in the sorry, relax, my bad. So you're gonna have like 4+ in the 4+ in the lower limb and 3+ in the upper limb. Why? Because there's more weakness in the upper limb than in the lower limb. That was correct. Okay. So for example, 4+, you know how to measure it, right? You know strength, it's out of 5 for muscles and movement. So like, let's say it's 4+ in the lower limbs. It means very barely, it's faintly affecting the lower limbs, but in the upper limb is 3+. This is too much details. No, it's not going to get into that. My whole point of central cord syndrome is for you to understand if you have upper limb weakness more than lower limb weakness, this is central cord syndrome. Tayyib? Okay.
Excuse me, doctor, I have a question.
Yes.
In the syringomyelia, we don't also have lower limb dyspareunia.
No.
So it's the upper limbs also.
Yeah. Just upper limb.
Would that not confuse us in the...
Because the spinal thalamic tract is not destroyed. It's just compressed. Because there's something growing in the central canal. Spinal thalamic tract is intact. It's okay. But at this lesion, somewhere like between, I don't remember exactly, somewhere like at the lower cervical portion, down to like, let's say T4, somewhere along that area, or down to T8, I don't remember the exact location, but somewhere in that area, you get a cancerous growth, for example, or a thickening of whatever. There's something on the inside that is growing and it is compressing the anterior commissure. It's not even touching the spinal thalamic tracts are perfect, but it's just touching the anterior commissure where the peripheral spinal nerves going to the spinal thalamic tract are crossing over. So you only get loss of pain and temperature in the upper limb. The spinal thalamic tract is not touched. It is perfectly working. Okay? Type. What was I gonna teach here? Okay. Type. We ask ourselves, this one is pretty simple. Okay. So corticospinal tracts, ventral horns, okay, and this above here is going to be these are the spinal thalamic. Whatever, for the sake of this case, I'm going to have, let's say, spinal thalamic tract is gone bilaterally. What do you think of? How will I present?
No. Loss of pain and temperature.
Bilateral loss of pain and temperature below the lesion.
Guys, I'm saying ventral horns. Ventral horns are gone.
Oh, ventral
horns.
Okay. Lower motor.
Lower motor neuron lesion.
Excellent. Lower motor neuron lesions. Bilaterally or unilaterally?
Bilaterally.
Bilaterally. Okay. Type. What if I also damage the corticospinal tracts bilaterally? Now, what presentations will I have?
Upper motor neuron lesion. Bilaterally.
Okay. And what if this is happening in all the body, in all the ventral horns and spinal thalamic tracts because of a mutation?
Superoxide dismutase.
Okay. So in this case,
ALS.
ALS?
Yeah.
Okay.
Doctor, I have one question. At the level of the lesion, due to damage of the corticospinal tract, is it at lower motor neuron lesion at the level of the lesion?
At the level of the lesion, it will always be lower motor neuron. But this is when we're talking about traumas, stab wounds, car accidents. In ALS, it is an autoimmune disease. So the rule doesn't apply. In ALS, you get a mixed lower motor neuron plus upper motor neuron presentations. That's all there is to it. You don't get no sensation.
So even at the level of the lesion, you're gonna have upper motor.
I'm gonna explain it in just a second. I'm gonna tell you in just a second. Okay. So you have no sensation manifestation. Everything is good. Okay. Your sensation is excellent, and you have no, for example, urinary incontinence. It's all good. Okay. So the only thing you have is a mixed lower motor neuron, upper motor neuron lesion. What does that mean? Let's say you do reflexes. Reflexes, deep tendon reflexes are brisk. Okay. So you know they're hyperreflexia. And some parts of the body, let's say the lower limbs, for example, you have spastic paralysis. You know what? Let me make your life easier. Even the upper limb, let's say spastic paralysis. Okay. But and you look at the patient's, for example, tongue. Okay. And you see there's fasciculations. Okay. Fasciculations are characteristic for lower motor neuron. You see dysarthria. You see, et cetera, et cetera, et cetera. So when you have a mixed picture, even though the majority of it looks like it may be an upper motor neuron lesion, but you also have signs of lower motor neuron lesion, then you're going to think of
ALS.
Okay. Type. The second thing I'm going to mention. The second thing I want to mention is, let's say we only damage the ventral horn, like we just said. This is super important. You need to ask yourself instantly. One, this is going to be a lower motor neuron lesion, right? So you're going to ask yourself, is it unilateral lower motor neuron, meaning flaccid paralysis, hyperreflexia, hypotonia, etc.? Or is this bilateral? Okay. If it is bilateral, you have presentation of lower motor neuron and flaccid paralysis, fasciculations, hyperreflexia, hypotonia. In a baby, for example, he's born with it. Then you're going to think, come on, remember bilateral, I told you, it's always going to be autoimmune diseases, genetic mutations, yada, yada, yada. So in this case, what syndrome is this?
Spinal muscular atrophy.
Excellent. Spinal muscular atrophy, also known as Wernicke-Hoffman disease, right? SMA, and it is caused by mutation in SMN1 gene, okay? And it's also autosomal recessive. I don't think you need to know all of this. Okay, so what did I tell you? Is it unilateral or bilateral? Let's say, wow, excellent, okay? Let's say that the lesion was just unilateral. If it's unilateral, lower motor neuron, then we can think of things like peripheral neuropathy. Okay. Maybe the ventral horn is not even damaged. Maybe it's just the motor peripheral nerve, right? Or maybe it's an infection. What infection has a tendency to damage the lower motor neuron and can be unilateral or bilateral?
Is it polio?
Excellent. Yes. So it is polio. Okay. Now, why am I doing all of this? I know you can revise it, and I know my job is not to help you memorize everything right now, but I'm just trying to make you understand my approach. In urology, you have to isolate symptoms. You have to ask yourself instantly, is it unilateral or bilateral? It instantly gives you an idea. Then you ask yourself, is it motor or sensory? You got to take things step by step. If it's motor, you look for signs of, for example, look for signs of lower motor neuron. No, everything is upper motor neuron. Look at your answers. Exclude anything that was saying lower motor neuron, because the symptoms are all hyperreflexia, hypertonia. There's nothing about lower motor neuron. So look at the answers and you see SMA, you cross it out. You know 100% that's not it. You look at polio, you cross it out. You see diabetic neuropathy, you cross that out. Then you're left with example, let's say ALS, and you're left with, let's say, I don't want to mention it because I didn't get into it yet. Let's say, for example, a stroke, right? Which we didn't cover right now. A stroke is in the cortex. That's an upper motor neuron lesion, okay? Once you exclude everything, you're going to be left with two options. These two options, you're then going to look at further details. Like, is this one unilateral or bilateral? Does this have sensation or not? If it has sensation, is this a spinal thalamic tract? You look for pain and temperature. Pain and temperature are good, then you exclude anything that involves the spinal thalamic tract. So your job for neurology is to just remember what disease affects what tract. The rest is all understanding, okay? Bye. Okay, the last one of the spinal cord, then we can take a 5-minute break, and then I can finish the brainstem in 20 minutes, inshallah. The last thing I'm going to talk about, and I'm going to tell you what the disease is, because in this case, the disease is self-explanatory. And then we're going to draw it out together. So this time we're going to do it the other way around. Rather than giving you symptoms and then asking you what it is, I'm going to spell out the disease for you, and then we're going to talk about it. So what is this?
Subacute combined degeneration.
Yes.
Excellent. Now this disease actually spells out the tracts that are going to be involved, okay? Clear?
Yes.
Now let's fill them out. Spinocerebellar tract. And it's going to be bilateral or unilateral?
Bilateral.
Bilateral. Corticospinal tract. So spinocerebellar, they're gone. You're going to have ataxia. You're going to lose proprioception. You knocked out the corticospinal tract. You're going to have upper motor neuron lesion bilaterally. Spastic paralysis, hypertonia, hyperreflexia. Dorsal column is gone, along with Lesions tract, which we don't care about, but I'm just trying to sound fancy, as well as the deep tendon reflexes. Interesting? Is that understood? Yes. When you see this combination, the disease spells it out. If you ever see in a scenario ataxia, ask yourself, corticospinal tract, is it affected? Ask yourself, is the spinocerebellar, is the dorsal column affected? If they both are, then you instantly know what this is. Now, what is subacute combined degeneration caused by?
Deficiency in the B12 deficiency.
What other vitamin can present very similar to subacute combined degeneration?
I think calcium.
No, vitamin. I already gave you. Vitamin what?
Deficiency.
What is it?
It could be due to copper deficiency also.
Now, please notice, I have a very similar lecture that I gave last year in a review. And in my review, I accidentally said vitamin E toxicity. That was wrong on my behalf. So in case anyone has a link for that lecture and is watching it for whatever reason, this is the right thing, okay? It is vitamin E deficiency. Okay, type. So I think I pretty much covered all the diseases of the spinal cord. Now we're gonna go into the brainstem lesions. And believe it or not, the brainstem is actually easier. But can we just have a 5-minute break, if that's okay, and then we can continue?
You sure?
Okay. Type. So we're gonna resume in 5 minutes, okay? What's up?
Yeah, doctor, the fasciculation is upper or lower motor lesion?
The what?
Fasciculation in the tongue that we see.
Lower. Capital letters. Lower motor neuron. Specifically, when we're dealing with the nuclei of the face, and specifically fasciculations are characteristic. I mean, you can see them elsewhere, but usually they're seen in the tongue, and specifically the lateral tongue. Okay?
Yeah, okay. Thank you, doctor.
You're welcome. Okay, can we start? By the way, I can't read any of the chats. You can see my screen. I can't see anything. So just use your mics when you can. And do me a favor. It might get a little confusing right now when I start engaging in the brainstem, but I promise you I'm going to clear it out. So just hold your questions just so that I try to finish and not take too long. So can everyone hear me? Can everyone see the screen? And can we start?
Yes, Doctor.
Okay. I need one person to remind us what my golden rule number 1 was.
To know bilateral or unilateral.
So that's what you ask. When you do a clinical scenario, that's your approach. Your approach is you ask 1, is it bilateral or unilateral? And 2, is it motor or sensory or both? But there was a golden rule for the symptoms. That golden rule was, if the dorsal column and corticospinal tract are damaged ipsilaterally, and the lateral spinothalamic tract was damaged contralaterally, the lesion is always going to be in the spinal cord. If we have loss of corticospinal or movements of the body, paralysis or weakness, loss of the dorsal column, all sensation except pain and temperature, and loss of the spinal thalamic, which is pain and temperature, all of them are lost contralaterally, then we know for a fact the lesion is above the decussation in the lower medulla. Is that clear? That is our golden rule number 1, okay? So for brainstem lesions, there's a very simple advice that I want you to know. You obviously are going to know it's a lesion in the brainstem because you're going to have cranial nerve involvements. So we know that. But sometimes it gets confusing. You lose track of, is it right or is it left? So the tip to understand from my golden rule number 1 is whenever you're lost or you don't know what you're doing, look at the corticospinal tract. Okay? If you're dealing with a brainstem lesion and you don't know what's happening, if it's right or left, look at the corticospinal tract. The lesion in the brainstem will be opposite to where you have weakness in the body. Is that clear? Before I even begin anything.
Yeah, clear.
Okay. So brainstem lesions. We're going to look at the golden rule number 2, and you have to memorize this. It's the rule of 4. 1, 2, 3, 4. That is in the midbrain. 5, 6, 7, 8. That is in the pons. 9, 10, 11, 12. That is in the medulla. What am I referring by these numbers? I'm always referring to the cranial nerves. Okay? So golden rule number 2 is you align these numbers to fit the 3 sections of the brainstem. And we know the sections of the brainstem. They are numerically ordered. Right. So why am I saying this? Because when we have symptoms of cranial nuclei and not corticobulbar tracts of the cranial nerves, which I will explain, don't freak out, then we can instantly have an idea where the lesion is based on the symptoms. So again, just like everything in neurology, you isolate symptoms and you ask yourself, what causes this? If it's a symptom in the body, you ask yourself, pain and temperature. What is responsible for pain and temperature? It is the spinal thalamic tract. In the midbrain, you can ask yourself, for example, you have ptosis, which is drooping of the eyelid, which is responsible by parasympathetic innervation, which elevates the levator ani. And you have mydriasis, which is dilation of the pupil, which means loss of parasympathetic innervation, because parasympathetic innervation is responsible for meiosis, which is constriction of the pupil. And your pupil is looking, for example, down and out gaze, which means it's inferiorly and laterally. Then you know that all the muscles of the eyes are innervated by the oculomotor except the lateral rectus, LR6, SO4. The lateral rectus is responsible by the abducent, and the superior oblique is innervated by the trochlear. The superior oblique actually makes the eye look down. The lateral rectus makes the eye, abduct. My bad. Okay, so when the oculomotor doesn't work, the lateral rectus by the abducent is working fine. So it will shift the eye out because it's abducted. It's taken out, the lateral rectus. It goes laterally. And the trochlear, because it's working, it's going to shift the eye down. So the gaze of damage to the oculomotor is known as down and out, okay? So for example, if I have that, okay? So initially, my understanding is on the vertical location, my lesion is gonna be in the midbrain. Type. What if, for example, I have a lesion where my tongue has fasciculations and it is shifted to the right? What's responsible for the tongue? I have to go back. Responsible for the tongue is the hypoglossal nerve. So I know the hypoglossal nerve is damaged. So where is the location most likely to be? In the medulla. So that's just a general approach. Now, when we're talking about the nuclei, the cranial nuclei of the hypoglossal nerve, the nerve responsible for innervation and movement of the tongue always speaks. So it will go towards the lesion. Okay? If it is at the level of the nuclei, we're keeping it very simple right now. So does everyone understand this concept? And if I have, for example, let's say facial paralysis, what's the facial nerve? It is facial nerve number 7. And I have nothing else. I have everything else is okay. There's no hypoglossal, there's no oculomotor. I only have facial paralysis. Then maybe I have an idea. There's something wrong in the pons. Okay, is this clear? So vertical location, we go by the rule of 4. Next, we need the horizontal location. And the horizontal location is very simple. If the symptoms, again, we always ask ourselves, is it motor or is it sensory? If it is only motor symptoms, then the lesion will always be medial. If we have both motor and sensory, then the lesion is lateral. Is that clear?
Yes, doctor.
Yes.
Okay, so golden rule number 2, we create the rule of 4, we plot our symptoms, we know what nerves they are, what cranial nerves, and we have an idea where it is vertically located. The second portion of this golden rule is we look at the symptoms. Are they only motor? Then I know for a fact this is in the medial, somewhere medial in the brainstem. If it's motor and sensory, then it is lateral. Okay. Now, here's where it gets a little confusing, okay? And I just want your attention because it's actually super easy. Now, before anything, I drew 2 question marks over here because I want to emphasize that I am well aware that cranial nerve 1 and 2, olfactory and optic, are not in the midbrain. But this is just for the sake of explanation and to make you remember the rule of 4 to answer any clinical question. I'm not teaching you anatomy, I'm teaching you clinical anatomy, okay? Right. So let's make things a little complicated now. We all understand the concept of the spinal cord, right? In the spinal cord, at the level of the vertebral body itself, we have the ventral horns, which are lower motor neurons, and we have the cortical spinal, which are upper motor neuron, and they ascend to relay in their second and third order neurons and whatnot. Well, actually, the cortical spinal, they descend, but let's not go into that, okay? Well, guess what? In the cranial nerves, there's the same exact thing. The cranial nerves equal the ventral horns. It's the same concept. They are all lower motor neurons. Okay? So the cranial nerves themselves, if you damage them at their respected location, so 9, 10, 11, 12 in the medulla, 5, 6, 7, 8 at the pons, and to be specific, 6, 7, 8 at the junction of the pons and the medulla, and 3 and 4 in the midbrain. If you damage them at their respected levels, isolated damages, they will be ipsilateral and they will be lower motor neurons. Why am I saying all of this? Let's look over here. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Now we all know for a fact that at each cranial nerve nuclei, we have peripheral motor nerves or sensory nerves that either go to move certain muscles in the face or come from the face and go into the brainstem to send sensory information. That's simple. That's clear, right? Now, here's the little trick. From the brainstem, do these nerves disappear? No. Does the brainstem understand what these messages or inputs mean? No, they do not. They need to go to the cortex. Just like the corticospinal tract needs to ascend and ultimately relay in the cortex, in the frontal cortex. The cranial nerves have to do the same exact thing. So there's another rule now. When you look at a lesion in the midbrain, for example, the oculomotor, because the oculomotor is present in the most superior portion of the brainstem. We all know that the midbrain is the highest. It's the #1 section in the brainstem. If we have damage of the oculomotor nerve, then the lesion must always be in the midbrain. It cannot be in the medulla, right? Because these descending fibers coming from the cortex, they innervate the oculomotor at the midbrain. There is no longer anything oculomotor, for example, going below. It doesn't need to go below. So if the oculomotor is damaged, then we know for a fact that we have a lesion in the midbrain. Okay, and what is this tract called that is coming from the cortex to innervate the oculomotor at the nuclei in the midbrain? This is known as the corticobulbar tract. And the corticobulbar tract is not just to the oculomotor, it is to every single cranial nerve. So the higher function upper motor neuron tract responsible for the body is called the corticospinal, while the higher process upper motor neuron tract that is responsible to innervate the cranial nerves are known as the corticobulbar tracts. Okay, so golden rule number 3, and I'm gonna go back up here in just a second. But golden rule number 3, lesions of the corticobulbar tract. It's the same concept as lesions of the corticospinal tract. The corticobulbar tract lesions are the upper motor neuron lesions of the cranial nuclei. Just like the lesions of the corticospinal tract are the upper motor neuron lesions of the ventral horns. So in a nutshell, the corticobulbar tract is pretty much the same exact thing as the corticospinal tract, but it's just in different location. Now we're talking location. Upper motor neuron, lower motor neuron, like I said in the very beginning, is not location. Corticobulbar tract is in the face. Corticospinal tract is in the spine. Clear? Just like the cranial nuclei. They're the same concept as the ventral horn. In the ventral horn, remember we said each spinal segment had its own ventral horn in the gray matter. Well, in the midbrain, you have 4 nuclei at each location, at each segment of the midbrain. So the cranial nerves are the same concept as the ventral horns, and the corticobulbar tract is the same concept as the corticospinal tract. So now why am I saying this? Because guess what? And this is where the brainstem gets a little confusing, is that in brainstem or cranial nerve lesions, we know the functions of the cranial nerves, we know what they do, but sometimes they get a little confusing and they disorient us in terms of location. Is this ipsilateral? Is this contralateral? As a rule of thumb, in the cranial nerves, if it's lower motor neuron, meaning something is damaged at the site of the cranial nerve itself, then it's going to be ipsilateral. If it is upper motor neuron lesion of the corticobulbar tract, meaning the lesion is here above the midbrain, then it'll be damaged contralateral. So now the question is, how do you know? So it presents and with the same symptom. The tongue deviates either towards the lesion, for example, the hypoglossal nerve, in a lower motor neuron, the tongue speaks, so it goes towards the lesion. In an upper motor neuron lesion, it's always contralateral. It will go away from the lesion. So how do I know? How do I know what I'm dealing with? Rule number 1, look at the corticospinal tract. Remember, I told you. You look where there's weakness in the body. If it's weakness on the left, then my lesion's on the right side, 100%. I look at the hypoglossal nerve, and I see that the tongue is shifting to the left. Okay? So now I know that this is going to be an an upper motor neuron lesion of the hypoglossal nerve. Meaning, is the lesion at the medulla? No, it's probably above. So I need to look for other cranial nerve symptoms. For example, the oculomotor. So to summarize and make it a little simpler for you, let's say we have a lesion in the midbrain. This is our lesion. Okay. And this is, let's say the lesion is left-sided. Okay. So I have a lesion in the left midbrain, let's say. Okay. Type. What symptoms do I have? I have left eye down and out gaze, and I have ptosis, and I have mydriasis. Okay. So what cranial nerve is damaged? For sure, 100%. What cranial nerve is this?
Oculomotor.
Exactly. Okay, so cranial nerve 3. Okay, but guess what? I also have right-sided tongue deviation. Okay, let's look at this simply. One, tongue deviation. What cranial nerve am I dealing with?
12.
12, right? So I know 12 is it should be damaged, right? But the oculomotor is also damaged. So something is up. I know that the hypoglossal nerve is located in the medulla, but the oculomotor is in the midbrain. So what on earth is happening? So I need to pause for a second and remember, wait a second. The lesion's on the left, right? So why is the tongue, and I know the tongue speaks, if the hypoglossal nerve is damaged at the lesion, it should go towards the side. It should go to the left. But for some reason, it is going to the right. So what is happening? The tongue is deviating away from the lesion. This means what? This is an upper motor neuron lesion of the hypoglossal nerve. Why is that happening? Because again, my lesion is at the level of the midbrain. Here it is. The lesion is affecting the corticobulbar tract of the hypoglossal nerve. So why is the rule of 4 so important? Because when you look localized symptoms, so oculomotor, you circle it, and then you have tongue deviation, you circle the hypoglossal nerve. We said the lesion is in the left, so we're going to have right-sided body paralysis, right? Because the corticospinal will always be contralateral, and sensation loss in the body, just to add the spinal tracts in this. So the first thing you do, you said we circle the oculomotor, we circle the hypoglossal. Then what do? Just by looking at this, by the rule of 4, if I have 2 cranial nerves that are involved, but one is higher than the other, then I know instantly the lesion is higher at where the higher nuclei is damaged, because I know for each nuclei, there are corticobulbar tracts ascending to the cortex. And if there are nuclei below the midbrain, they can also be damaged at the level of the midbrain because they have descending corticobulbar tracts. How do I confirm? I know the lesion's oculomotor at the level of the midbrain, right? So I know the lesion is at the midbrain. How do I confirm? The lesion below, whether it's in the pons or in the medulla, for example, has to be what? No matter what. What does it have to be?
Upper motor neuron.
Okay. The second you get that, you can confidently put your answer as midbrain or somewhere higher than the medulla. The second you see, you will have a cranial nerve in its respected location, but it's presenting as an upper motor neuron, then we know for a fact that the lesion is above. How do we confirm that? We look at other symptoms. We have symptoms of the oculomotor nerve. It is higher than the medulla. It is in the midbrain. So we know the midbrain oculomotor nerve is a lower motor neuron affecting at the level of the midbrain. While the lesion of the hypoglossal nerve, which is located in the medulla, it is an upper motor neuron because it is shifting away from the tongue. How do you confirm it's an upper motor neuron? You check the tongue. Is there fasciculations? There's no fasciculation. It's shifting away. Khalas, upper motor neuron. So the lesion is where? Midbrain. Okay? Now, generally, the next thing you'd ask yourself was, is it just motor or is it motor plus sensory? And you will know instantly. For example, we knew the symptom was location, we said midbrain. The next thing you would do is ask yourself, is it lateral or medial? But here's a little trick. The midbrain, we don't do lateral versus medial. Lateral versus medial is only in the pons and medulla. The midbrain, the syndromes, Weber and Benedict, which I'm going to explain in just a second, are anterior versus posterior. Okay? Is this clear?
Yes.
Yes.
Okay, and I'm going to make it even clearer just now. Type. So before I go to the special nuclei, let's just look at this one more time. One, the golden rule, the corticobulbar tracts are the same concept as the corticospinal tracts. The cranial nerves are the same concept as the ventral horns. We can damage the cranial nerves, but it will be a lower motor neuron lesion, just like if we damage the ventral horns. The cranial nerve, lower motor neuron lesions, meaning they're at the level of where they belong, and we know where they belong by the rule of 4, they will be ipsilateral. Okay, if we damage the corticobulbar tract of certain cranial nuclei, there must be a cranial nuclei above, for example, in the midbrain that is damaged at its level. For example, if the lesion was at the midbrain, if the lesion was in the brainstem. Okay, and the corticobulbar tracts are upper motor neuron lesion, and they are contralateral. So lower motor neurons of the cranial nerves, it'll be damaged at the nuclei itself, or its peripheral nerve that comes out to supply the face. The lesion will be ipsilateral. This is golden rule number 4. Clear?
Yes.
Okay. Fine. Now we have 2 exceptions, and I don't want to call them exceptions. They're 2 special nuclei. The facial nerve is number 1. And they're special because I promise you, you will get MCQs on it, and whatever case scenario they bring to you, the difficult ones, or if it's SAQ, I promise you they will involve the facial nerve or the trigeminal nerve. So for starters, let's look at the facial nerve. I drew 2 cerebral cortexes over here. Both cortex are present. We have the right and we have the left, okay? So for the sake of this example, I'm taking the left side, the left cortex, the left facial nuclei, which is present in the caudal pons, right? Because cranial nerve 7 is at the junction of the pons and the medulla. And I'm taking the left face. I don't care about the right face, okay? Fine. So the left facial nuclei is actually 2 segments. And it receives one ipsilateral innervation to the facial nuclei, and it receives 2 contralateral innervations from the right cortex. Are we clear so far? The facial nerve then, or the facial nuclei, supplies the lower 2/3 of the face and the upper 1/3 of the face. Is that clear? So why am I saying all of this? Because if I have a lower motor neuron lesion in the facial nuclei, it means I'm either going to destroy the facial nuclei itself, or I'm gonna destroy the peripheral nerves. Like you get a cut in the face, for example. So guess what's gonna happen? All input to the face is destroyed. So you lose your ability to move all the muscles in the face. So lower motor neuron equals ipsilateral portion of the face, and it is the full face. The entire face, okay, is affected. Okay. Option number 2. If I were to have, so we said this is the facial nuclei, right? These are the facial peripheral nerves. And the ones over here, guess what these are? These are the corticobulbar tracts of the facial nuclei, correct? Okay. So let's say I got a damage in the right, I got a stroke in my right cerebral cortex. Or I got some lesion or a stroke or whatever somewhere along the, it could be, for example, in the midbrain, right? Because we're talking about the lower pons. This here is lower pons. So let's say this is somewhere in the upper midbrain or even above the brainstem. Guess what's going to happen? I lose all sensation or input, sorry, I lose input from the contralateral cortex. But guess what? The ipsilateral innervation is still okay. So guess what's going to happen? So you see this is one. Sorry, let me use another pen. So this is one input that's going to go away to the upper portion of the facial nuclei. Here's another portion that's from the contralateral cortex that goes to the lower facial nuclei. But guess what? We have this portion of the ipsilateral innervation, which still supplies the upper portion of the face. So in an upper motor neuron of the facial nuclei, you will get, which portion of the face is this? Left. Where was my stroke? Right. So it is contralateral. And did the entire face get damaged, or did we have sparing of the forehead because of the ipsilateral innervation? We had sparing. So you get forehead sparing. You ask the patient, raise your eyebrows, and they can raise it. Okay? So lower motor neuron, damage of the facial nerve, which was here. There is absolutely no innervation to the face, so you lose the full face, and it is on the same side, right? It's on the same side, so it's ipsilateral. While contralateral damage of the upper motor neuron or the corticobulbar tracts, you will get contralateral damage and forehead sparing because of the ipsilateral innervation. Clear?
Yeah, doctor, I have just a small question. You mean full face, the whole left side, right? Not
the whole
both.
left side. Yes, yes,
Yeah,
yes. We're
okay.
only talking about the left. There is no right portion. Yeah, just
Yeah.
forget all this. We're talking about the left, right? Because I told you, the lower portion of the facial nuclei supplies the lower 2/3, while the upper portion of the facial nuclei supplies the upper 1/3. I promise, guys, wallah al-azim, this is MCQ, SAQ, ask kul haj, takhbis. Okay? So please, just make sure you understand this. It's everywhere. Okay? Clear? Fine. The next nuclei, and it's another confusing one. So here's the facial lesion rule. One more time. If it's a lower motor neuron, it will be ipsilateral and it will affect the whole face. Okay? If it's an upper motor neuron, the corticobulbar tract of the facial nuclei, or for example, a stroke somewhere in the cerebral cortex, then it will be contralateral face and it will spare the forehead, meaning raise your eyebrows and you will be able to. Okay? So when you ask a patient, comes to you with facial paralysis and you ask him raise your eyebrows and he raises it and he's able to do it, the patient thinks this is a good thing. No, this is actually really bad. Yes, the patient raise your eyebrows and he can't, then you know it's good. Because if it's a lower motor neuron lesion, it could be, for example, Bell's palsy. And that's most commonly due to herpes virus infection. Okay, herpes, simplex virus infection. While if it's an upper motor neuron lesion, it could be a stroke. And strokes are just, let's just say bad. Like, the second nerve we're going to discuss is the trigeminal nerve. The trigeminal nerve is in the pons for the most part. Okay? Now, there's one exception. Before I explain the exception, you need to understand that the nuclei is divided into 3 portions. What are these portions? The mesencephalic nuclei, the principal or main, and the spinal trigeminal nuclei. So why is the trigeminal nerve the only nerve where it's separated into functional nuclei? The reason for that is because in the spinal cord, we have the spinal thalamic tract. We have the dorsal columns. In the face, we don't have different tracts. We just have the trigeminal nerve, which is responsible for sensation of the face. And remember, for sensations of the face, you had the V1, V2, V3, ophthalmic, maxillary, mandibular, right? But these are the nerve peripheral sensory endings. Even the nuclei itself has 3 portions. Why? Because it needs to have something responsible for proprioception, like the dorsal column in the spinal cord. The equivalent of that in the trigeminal nerve is the mesencephalic nuclei. So that's responsible for proprioception. Clear? The principal or main, I mean, the name gives it off, principal or main, this is sensation. The spinal trigeminal nuclei, from the name, like spinal thalamic, is responsible for pain and temperature. So where's the trick? Golden rule of the trigeminal nerve. The spinal trigeminal nuclei is actually located in the... Why am I saying this? Because at the level of the pons, let's say this is the left side, and I were to take the trigeminal nerve and just knock it out at the level of the pons, where it is, where it should be. This is a lower motor neuron of the trigeminal nerve. So you will lose, because it is left, you will lose left sensation of the face. You will be unable to have proprioception on the left, but you will lose right-sided pain and temperature. Why? Because the spinal nuclei is actually in the midbrain, and its ascending fibers are independent. So when you knock out the trigeminal nuclei, you're knocking out 2 nuclei, the mesencephalic and principal nuclei, and you get lower motor neuron. But guess what's ascending from the spinal trigeminal? You get the corticobulbar of the spinal trigeminal nuclei, and you knock that out too. So you actually have an upper motor neuron lesion of the spinal trigeminal nuclei. And like we said, anything cranial nerves, if it's upper motor neuron, then it is contralateral. Clear? This is the one trick in the cranial nerves. Is this clear?
Doctor, here the lesion in the pons, right?
Yes.
Okay.
And the whole trigeminal nuclei is, for the most part, present in the pons. But the spinal, the name gives it off, spinal, it's below. It's telling you, yo, I'm not in the brainstem. It's in the medulla. It is in the brainstem, but it's telling you, I'm below. It's not on the pons. It's in the midbrain. It's in the medulla. It's below the pons. So when you could, if someone is, trying to give you a very difficult question, they can tell you there's a lesion, affecting the trigeminal, only the trigeminal nerve. They can tell you trigeminal. They can tell you, for example, I'll give you a case right now. There's already a case that I wrote, and we're going to do right now. Okay, but if it's a lesion affecting the trigeminal nerve and it's on the left side, we know that for a fact. Why? Because we looked at the body paralysis. We have paralysis in the body on the right side, so we know the lesion is on the left. 100%. We're certain. We're confident. And we have left face loss of sensation and left face loss of proprioception, but we have right face loss of pain and temperature. So that gets us confused, but it's actually simple. It's because the spinal trigeminal nuclei, which is responsible for pain and temperature of the face, is actually located in the medulla, and it has to give off its ascending fibers, which at the level of the pons would be damaged, which would give you a concept of an upper motor neuron. Now, let me clarify one thing and make it very clear. Trigeminal nerve is a sensory nerve. In sensory nerves, we don't have anything called upper motor neuron or lower motor neuron, but it decussates. And I don't want to confuse you, so just remember it like this. It's fine. It works. It'll always be right. Okay? Just so that you guys don't get confused later on and be like, Hakim said this. No, anything sensory doesn't have upper motor or lower motor. But just remember it as the same concept, because it'll make your life easier in answering clinical scenarios. Clear?
Yes.
Okay. Excuse me. Okay. I'm going to give you a scenario right now, and we're going to see how we can solve it together. Okay? Wait one sec. Okay. Okay. So, 36-year-old gentleman with right-sided hemiplegia. Stop. That's it. That's all I care about right now. Right-sided hemiplegia. What does that mean? Instantly. What tract is affected? Someone tell me, is this motor or sensory?
Motor.
This is motor. Excellent. Is it upper motor neuron or lower motor neuron? They didn't really specify. So let's say spastic paralysis. Okay, so what is this? Upper motor neuron. So what tract is affected?
Corticospinal.
Corticospinal. So if it's corticospinal tract is affected on the right side, then if it's spinal cord, the lesion will be on the same side. Yes. If it is brainstem, it's going to be on the opposite side, right? Our golden rule number 1. Okay, so let's look at the question again. Very quickly, do we have any cranial nerves? Oh, okay, face paralysis, done. This is where? Brainstem or spinal cord?
Brainstem.
This is brainstem. So we know lesion is brainstem, 100%. Okay. Corticospinal tract is affected. Which side of the body is affected? Right side. So where's our lesion?
Left.
Left brainstem. Done. Okay, we know for a fact. Khalas. That's it. Half the question is already answered. Left brainstem. Okay. Type. We also have loss of sensation in the right side of the body. Excellent. So now we confirmed. We even know we have another clue to tell us that we're absolutely right. We have left-sided lesion in the brainstem. Okay, cool. Type. He also has left-sided face paralysis. All right, one step at a time. Face paralysis. What nerve is that?
Facial.
Facial. And that number?
7.
7. Okay, let me just get that out of the way. Okay. So we know the facial nerve. Okay. So maybe this is a left-sided lesion in the pons. Okay, that's what we're thinking of right now. When we think of the facial nerve, what's the number 1 question?
Lower motor or upper?
Excellent. How do we know that? You ask the patient to?
If it's ipsy or contralateral.
Just you ask the patient to do one thing, and you know how to
raise your eyebrows.
Raise your eyebrow. Let's go back to the question. Okay. Face paralysis. So he has left-sided. Let's say, one second. Left-sided. So he has left-sided face paralysis. I forgot what I was going to write here. I left it empty on purpose. 1 second. Left-sided loss of sensation of the face. Phenotype is lost on the right. So stick his tongue out. Okay, so it is, okay. Full face paralysis. So what do we know now?
It's a lower motor
neuron.
Lower motor neuron, which means where is the lesion? Ipsilateral or contralateral?
Ipsilateral.
Ipsilateral. Which side?
Left.
Left. Where did we say the lesion was?
Left.
So now we're super sure the lesion is on the left. Okay, type. What's the next thing? Left-sided loss of sensation in the face. Left side. Loss of sensation in the face. Where's our lesion? It's on the left, right? What's responsible for the sensation of the face?
Trigeminal.
We circle trigeminal. Is it ipsilateral?
Yes.
Yes, because it's on the same side where the lesion is. Okay, we're cool. But what's next? Pain and temperature in the face is lost in the right side. Do I freak out and start shouting and cry and give up on the exam?
Nope.
No.
Type. Why is that? What's the nuclei that is part of the trigeminal but is below the pons?
Spinal trigeminal.
Excellent. And therefore, this is an upper motor neuron, technically, of the spinal trigeminal nuclei. So we know still, where is the lesion? Is it in the pons or do we think more of medulla?
Pons.
It's still in the pons. Okay, طيب. You ask the patient to stick his tongue out. And it shifted to the right.
Mm-hmm.
The lesion is where?
It's still in the pons.
Left, right? The lesion is in the left.
Yeah.
Right. What nerve is responsible for the tongue?
12.
We circle 12 regardless. Just always circle. Don't be wrong. Don't get confused. Right. Is the tongue shifting towards the lesion or away from the lesion? Away. So it must be above the medulla. Okay, so now I am so sure that my lesion must be where?
In the pons.
In the pons. What's the next thing I need to do? Very simple. I ask myself, is it medial? Or is it lateral? How do I know? If it's medial, it's only motor symptoms. Yeah. Do I have a single sensory symptom?
Yes.
Yes. A lot.
So my lesion is what?
Lateral.
So my lesion, my answer is left. Lateral.
Pons.
This is as difficult as it gets. The fact that you answered this, you're good. Type. Quick recap. Just a quick recap. Lateral, or sorry, 1 second. Medial medulla. Which artery supplies it?
Anterior spinal.
Anterior
Excellent.
artery.
Medial medulla. So you're right. It is the ASA. Be specific though. Paramedian branches of the ASA. Type. What about lateral medulla?
Pica. The cerebral artery.
Pica.
Excellent. It is pica. Okay. Type. And pica is a branch of what?
The vertebral.
Vertebral artery.
Vertebral. صح عليكم. Okay. The last thing. Lateral pons. What's the artery that supplies it?
Anterior inferior cerebellar artery as well as branches of the basilar artery.
No. مش as well as. ICA is a branch of the basal.
Okay.
Okay. So guys, just so you never forget, because these two can get confusing. What's higher, the pons or the medulla?
Pons.
Pons. And then the medulla. What's higher, an A or a B?
A.
And if you're an Arab, you call pica as bica, so whatever. Just A is higher than B. So A is always supplying the pons, okay? So ICA is pons. Type. Why am I saying this? Because the other thing they can ask you about the super difficult scenario that we just answered, that we said is the left lateral pons, and I'm proud of all of you. What can they ask now? They can ask you, which of the following might be the causes, and they don't give you left lateral pons, right, whatever, medial, medulla. No, they just give you arteries. So you know the lateral pons is supplied by?
Pica.
So the left anterior blah, 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 or the basilar artery, they both are correct. Okay? Type. So what did we learn from all of this? In the medulla, or I wanted to recap here one more time. If you have a lesion at the oculomotor, somewhere higher up, then the lesion can't be below. It just can't. It doesn't make sense, right? But if you have a lesion below, it could be at the level of the medulla, or it could be higher. Why? Because of the corticobulbar tracts. How do you know? You assess if it's upper motor neuron versus lower motor neuron. How do you know? You look at the corticospinal tract of the body where there is paralysis or weakness. Please remember, weakness is a motor issue, okay? And you will know the lesion is contralateral. So the second you know that the lesion is contralateral, you will know that if you have a cranial nerve damage at its respective place, it has to be the same site where the contralateral corticospinal tract showed us. So if the contralateral paralysis of the corticospinal tract was left side, then we know that any damage of a lower motor neuron, cranial nerve, will be ipsilateral. It must be the same. If it's different, then you have to make sure, okay, wait, it's most likely upper motor neuron. So you look at the higher nuclei. Then you assess, is it ipsilateral? Yes. Okay, then the lesion will be instantly, khalas, okay, midbrain, for example. Is this clear? Is the concept, the rule of 4 and the lateral versus medial, is it clear for everyone? Can you answer all your clinical scenarios?
Doctor, can I just ask you a question?
Okay,
please?
Sure.
Just like when you said that, like, so the tongue deviates to the right side, but we still said that the that it's deviating away from the lesion. The way we confirmed it is because of the other symptoms, because they cannot happen on the same side. So we know that it has to be on the left, right?
Okay, so for the case of the tongue, number 1, you always confirm, you look at the corticospinal tract, you see where it is. If the corticospinal tract, you have paralysis on the left side of the body when you have a brainstem lesion, then we know the lesion must be right-sided. Number 1 rule is lower motor neurons of cranial nerves must be ipsilateral. Meaning, is it also right? If yes, then okay, that's where our lesion is. If no, then it's probably not. Number 2, for the hypoglossal nerve, if it's lower motor neuron lesion, the tongue will go towards the lesion. So we know the lesions are right-sided. The tongue must shift to the right. If it's shifting to the left, it's most probably, if it's shifting away from the lesion, it's a higher cortical function. Lastly, do you have fasciculations in the lateral tongue? Yes. This is 100% lower motor neuron of cranial nerve 12. Clear?
Yes, thank you, doctor.
Golden rule number 5, and I already mentioned it. Medulla and pons lesions are lateral versus medial. How do you know? If it's motor only, it is medial. If it is motor plus sensory, it is lateral. And this is super easy. So, hey, yo, what about the midbrain? No, midbrain is anterior versus posterior. And here's a quick section of the midbrain, because this is just very simple. I don't want to take more than just 1 minute on here. The midbrain, you have the crus, which is the anterior portion, and you have the tectum, which is posterior. The tegmentum, middle, it is the middle lesion. Okay. Wow, this is a doctor's handwriting right here. That's awesome. Okay. Anyways, so the crus is responsible, is the corticospinal tracts, basically, right? So the crus is movement. I don't want to say corticospinal. I'm just going to say motor. The crus is motor. Okay. So if you have, let's say, right-sided lesion in the midbrain, you will have a lesion in the spine, in the brainstem, will affect the corticospinal ipsilaterally or contralaterally.
Contralateral.
Contralateral paralysis. Okay. And in the midbrain, you're always going to have damage to cranial nerve 3. Always. Whether it's Weber or Benedict or whatever, you're going to have oculomotor damage. So you're going to have contralateral paralysis of the body and ipsilateral down and out gaze, which I explained, and ptosis and mydriasis. Again, because of the parasympathetic function of the oculomotor nerve, parasympathetic function, it does constriction of the pupil, which is known as miosis, and it raises the eyelid. When the parasympathetic function is damaged, you cannot constrict the pupil. Therefore, you get mydriasis, meaning dilation of the pupil because of the sympathetic because the sympathetic takes over because the parasympathetic is not working. Fun note, very quick, you can also get ptosis in Horner syndrome, and I don't want to confuse you. Horner syndrome is damage to the sympathetic trunk. Okay, and it's a triad of, you get meiosis, anhydrosis, and ptosis, which means dropping of the eyelid, no sweating, and you get constriction of the pupil, which makes sense because we said constriction is parasympathetic function. If the sympathetic trunk is damaged in Horner syndrome, then you're going to get this triad, including meiosis, which is parasympathetic activity. So my question is, why do we get ptosis when we lose the parasympathetic innervation? And why do we get ptosis when you lose the sympathetic? You lose it both. It's very simple. For the parasympathetic nervous system, it supplies the levator ani, which is one muscle responsible for lifting the upper eyelid. Sorry, there's another muscle, and I forgot what it's called. The superior, the frontal. I don't know what it's called. You can search it. There's another muscle, okay, which is supplied by the sympathetic. Believe it or not, there's a couple of muscles. Their one job is to lift the eyelid. So if you damage the sympathetic, there's only one muscle left to lift the eyelid. So it becomes weak and the eyelid drops. If you damage the parasympathetic, you lose the levator ani. You get just one muscle. I'm trying to, so hard to remember right now. I forgot what it was. The superior, the frontal, whatever. Okay. If you lose the parasympathetic innervation, you lose the levator ani, you're stuck with one muscle innervated by the sympathetic trunk, and you still get eyelid dropping. You need both of them to work to raise the eyelid. Okay. So let's go back. So when you have a lesion affecting the anterior portion of the midbrain, damaging the crus, you're going to have contralateral paralysis of the body and ipsilateral down and out gaze, as well as ptosis and mydriasis because of ipsilateral oculomotor nerve damage. This is called, what syndrome is this? This is Weber. Now, if you were to damage the middle portion of the brainstem, the tegmentum, you're also damaging the substantia nigra, which are responsible for posturing. So you get an ataxic gait. You get ipsilateral. Also, same thing. Ipsilateral oculomotor damage, so you get down and out gaze, ptosis, and mydriasis. And you damage the red nucleus. Does anyone know what the red nucleus is responsible for?
Rubrospinal tract.
Excellent. What's the rubrospinal tract responsible for?
Flexors, for flexion of the upper extremity.
Posturing. Exactly. Excellent. So let's put it this way. The red nucleus, which is in the midbrain, has upper or higher functioning innervation, which is from the cortex. Okay. Now, just like the lower motor neuron or the ventral horn of the spinal cord, the red nucleus is always active and it flexes the body. The higher orders, they inhibit the red nucleus from firing. So if you damage the inhibition, if you get an upper lesion in the cortex, a stroke, for example, and you damage the inhibition, which acts on the red nucleus to not flex the body, you're going to present with a flexor postural deficit. If the upper innervation is okay and it's managing to inhibit the flexing, but you damage the red nucleus itself at the level, there is no flexing, you get an extensor deficit. So when you get ipsilateral oculomotor damage, plus ataxic gait, plus or minus extension or a postural deficit, then you're going to think of the other midbrain lesion, which is responsible for the tegmentum.
Claude?
You mean
the Benedict syndrome? Yeah,
syndrome?
Exactly. Clear? That's the only two things. So in a nutshell, Weber is responsible for paralysis and oculomotor. As the name suggests, it's a web. You're stuck. All you have is contralateral paralysis, and anything in the midbrain will have ipsilateral oculomotor. Okay? That's Weber. Benedict, you're going to have everything else. Ataxic, gait, postural, oculomotor. Okay? So that's it. That's your midbrain. Now, because I mentioned the oculomotor so much, and guys, and this is super important. Please, please, please. I know I took way too long, but please focus right now. This is the last thing I'm going to talk about. I've mentioned oculomotor is in the midbrain 1,000 times, and that's an excellent rule of thumb. There is one exception. The medial lemniscal fasciculus. It is located in the posterior pons. What is the MLF? The medial lemniscal fasciculus is responsible for horizontal gaze. Okay. Now, what are we talking about? Again, please mind my drawing. So, you know what? Let's just give them some pretty lashes. Oh my God, fabulous. Okay. So you have right, or no, sorry. You have right and you have left eye. Okay. When I want to look to the right side, what pulls the eye inside? The left eye is pulled by the oculomotor nerve, while the right eye, in order for it to look to the right, it has to be abducted. And what muscle supplies the lateral rectus? We said the rule is always LR6, SO4. Never forget this. The lateral rectus is supplied by the abducent. So in order for me to have accurate horizontal gaze, I need something to connect my oculomotor with my abducent nerve to make sure they transition together. Right. When I want to look to the left, the right oculomotor, or sorry, cranial nerve 3, is gonna have to pull the right eye, and the left lateral rectus will abduct the eye. It's called lateral rectus, so this is going laterally. Okay, cranial nerve 6. Okay, in order to look to the left. Okay, so see this working harmony? This is called your horizontal gaze. Or else one eye is going to be, stuck, and the other eye is going to be looking to the left. Or one eye is not going to be able to move, and the other eye is going to have nystagmus. And I'm going to explain what that is right now. So if you have an ipsilateral eye, and you think it's the oculomotor, if the oculomotor is damaged, the oculomotor has parasympathetic innervation. You will have ptosis and you will have mydriasis. If you have something in the eye, there's no ptosis, there's no mydriasis, this is unlikely, not impossible, it's unlikely to be the oculomotor nerve. Number 2, if you have just one eye deficit, this is probably the oculomotor. Again, if it's functions of the oculomotor, which is all movement except abduction of the eye and downward gaze at the eye. Okay, fine. So what is the MLF? The MLF is a connection of cranial nerve 3, the oculomotor, cranial nerve 4, the trochlear, cranial nerve 6, the abducent, and even the cranial nerve 8, the ocular. Do I care about any of this? No, I don't. What do I care about? I care about abducent. I care about oculomotor. The rest can, try to figure it out, whatever. So 3 and 6. Fine. How do I know when and where I have a lesion in the MLF? Let's put it this way. I'm going to draw one more. Or you know what? 2 more, just for the sake of being completely thorough. Okay? As the name suggests, medial lemniscal fasciculus. Okay? We said, before I give you my mnemonic, we said it's cranial nerve, oculomotor cranial nerve, and the abducent. Can someone just tell me which nerve? Just assume which nerve I like more. Do you think I think the oculomotor is more important, or do you think I think the abducent is more important?
Oculomotor.
Oculomotor, yes, yes, yes. So how do I know where the lesion of the MLF is damaged? By looking where the oculomotor doesn't work. Where I look, there is an adduction failure in the eye that cannot adduct. For example, if I'm trying to look at this set of eyes right here, and I'm trying to shift the eye, but it's not moving, it's stuck to where it is, it's supposed to be here, but it's not, then which side MLF is damaged? Left side of the MLF. But hey, the MLF connects the oculomotor and the abducent together, right? So guess what the body's going to try to do? It's going to realize, my eye is not adducting. So it's the MLF, the left MLF, will start to overfire. It'll send more input. and more input. But hey, the oculomotor isn't working. No matter how much input I put, this eye is not going to come here. It won't. It's stuck where it is. So guess what's going to happen with the abducent on the other side, which is working? It's going to get so much stimulation that the eye is going to start going back and forth, back and forth, back and forth. And this is very rapidly. Okay? This is called nystagmus. Okay? So the mnemonic for MLF is medial failure. Tells you where the lesion is. Okay? The eye that cannot go medially, because you have your nose here. There's an ugly nose. There's no nose job or anything. Okay, so this eye does not go medially. So the lesion is on this side, the left side. Okay? Type. What does it mean? What do we call it when the medial lemniscal fasciculus is not working? Do we say we have a left medial lemniscal fasciculus failure? No. This is referred to as
lateral strabismus or something.
No, it's INO. Internuclear ophthalmoplegia. Okay? This is another, when you have a failure of the MLF, we refer to it as INO, internuclear ophthalmoplegia. This is another mnemonic. It tells you ipsilateral adduction failure, nystagmus opposite. This tells you where the lesion in the MLF is. So, one more time. I have two eyes. Okay? This is going to be the right. This is going to be the left. Here's that ugly nose that we were talking about. Let's say I'm trying to look to the right side. The left eye is stuck. It's not going. It's not going medially. It's not adducting. And the left pupil is just going crazy. It's going back and forth and back and forth. So do I have a lesion of the MLF, or do I have a cranial nerve 3 oculomotor nerve damage right now? What is this? MLF. Is it the left or the right MLF?
The left.
The left. Why? Because we said it's where the oculomotor nerve doesn't work. We also said it's where you have medial failure. The eye cannot go medially. So again, this is the left MLF. We also said, INO, we have ipsilateral adduction failure. I cannot, if the lesion's on the left, I cannot have the same eye look, cannot have it adduct. And I will have nystagmus on the opposite side of the lesion. Okay, clear? This is your MLF, and this is referred to as what? Left MLF failure, or do we call this as left INO?
Yeah, left INO.
So where is the lesion?
On the right.
Huh?
On the left medial longitudinal fasciculus.
In the left INO. Yeah. Which is where? Where is the MLF? It is in the posterior pons. Left posterior pons. That's where my lesion is. Clear?
Yes.
Okay. I feel like half of you fell asleep. I have no idea how many people are left. Like, this covered everything. I think, yeah, this is definitely everything. I'm going to take 2 questions just because I'm absolutely exhausted. When is your exam, by the way?
Sunday.
Sunday. Okay, good. Okay, any questions, or was this clear?
Doctor, just a small question. The INO is always with the posterior part of the pons. Since I know that also the medial longitudinal fasciculus also in the midbrain, like the lower part of the midbrain. So once I have the MLS or the INO, I should directly think about pons or like depend?
If it's isolated. If you have other symptoms, you have to trace everything.
Yeah. Okay.
And the way you answer neurology is by exclusion. Don't think you're smart and go for the answer. Even I get wrong answers when I'm doing my step 3, for example, neurology questions. If you try to be smart and jump to the answer right away, even if it's super obvious, you might get it wrong and you won't ever know. But I promise you, if you understand what you're doing and you're solving by exclusion and you look at all the options and you make sure that the wrong options are actually indeed wrong, then you'll always get the right answer. So in the easy questions, you want to go ahead and pick the right answer instantly because you're confident with what you know, sure. But any tricky question, even if you're confident with your answer, make sure you exclude all the other choices. Okay?
Yeah.
Type. One more question.
Doctor, I have a question regarding the spinal cord. The charts we usually say that what will happen at the site of the lesion and below it. Regarding the dorsal column, is there anything will happen below the lesion as well? Like it's ipsilateral at the site of the lesion and below it?
No, dorsal column will always be ipsilateral sensation loss if it's in the spinal cord.
At the site of the lesion only?
At the site of the lesion, I mean, okay. So if we're talking about the majority of dorsal column involvement is going to be, for example, autoimmune or the nutritional deficiencies. In that case, no, you're just going to be able to see it below the lesion. Now, in all textbooks, no one ever says ipsilateral. No, hold on. Sorry, it will be ipsilateral. Yes, 100%. 100%. Dorsal columns will be ipsilateral everywhere. At the side of the lesion, below the lesion, it doesn't matter.
Okay.
100%. Okay?
Yeah, okay, thank you.
You're welcome. Anything else, guys? Yalla, one more. I hope this was useful.
Doctor, can you please share these notes?
So here's a little confession. This is my first time ever using an iPad. I have no idea what I'm doing. Sure, I could, but the issue is like I've been scribbling all over it and writing over it. I like erased some stuff as I went, so it might not be fully accurate, but I think the whole lecture is recorded. I'm more than happy to send it to you, but I wouldn't necessarily advise to study from it because it was interactive. I wouldn't advise you to, you know what I mean? I wrote over so many things, I scribbled too many times, I erased it. I'm OCD. Yeah. This is not a note that I'm proud of.
Yeah, I understand. Thank you.
You're welcome. Guys, there's a recording I have, the same session that I gave last year. There's a YouTube link in your seniors Dropbox. There's also another lecture that I gave. It's a pathology review. It might be a little bit more advanced. I don't know if you guys took the cortex lesions, dominant spheres, non-dominant, etc. Or I don't remember if that was after your midterm or below or before. But I described the cancers in detail, the pathology, how to answer them. So if you do have the time, make sure to look through your seniors Dropbox. I'm pretty sure the links are there. If you can't find them, let me know and I'll try to find them and send it to you on my own.
All right, thank you, doctor.
You're welcome, my pleasure. Okay, guys, thank you, everyone.
Thank you so much, doctor.
Thank you, doctor. It's a very useful session, really.
Thank you so